The eyes are the windows to the soul, or at least the poets say so. Well, I'm no poet, but I can tell you this much. The condition of our eyes is definitely a window to your health. Today, with the number of non communicable chronic diseases on the rise in our country, such as heart disease, diabetes, high blood pressure, fatty liver, these conditions do have an impact on our eyes. Some of these conditions, if left neglected, can also lead to blindness. So, in order to throw some light on how chronic non communicable diseases can impact the health of our eyes, with us today on the Wellberry is Dr. Gairik Kundu. Dr. Kundu is a specialist in Cornea and Refractory Services at Narayana Nethralaya in Bangalore. He is also involved in some cutting edge research which looks at artificial intelligence, AI, in refractory surgery. Dr. Kundu is doing his PhD from the Maastricht University in Netherlands, where again his PhD is based on the use of artificial intelligence in keratoconus and refractory surgery. But before inviting Dr. Kundu to the platform, let me introduce myself. I'm your host, Dr. Nirmala, and here at the Wellberry, we are involved in educating you and giving you correct information about health and also about nutrition. So now, without any further delay, let's welcome Dr. Gairik Kundu and let's see what he has to say about eye health and chronic non-communicable diseases. So, Dr. Gairik, welcome to the Wellbeing YouTube channel, and thank you for taking the time to explain eye-related problems in chronic non-communicable diseases to our viewers. So, let's go ahead and start questions right away, right? So,
yep.
What are the eye-related problems that we see today in people with non-communicable diseases such as diabetes, hypertension? So what are the kind of issues that people are facing where their eye health is concerned?
So I think a recent thrust on non-communicable diseases, especially diabetes. India is the diabetes capital of the world, and especially when you have these chronic diseases such as hypertension or such as diabetes, it not only affects the other organs like the liver, the kidney. Invariably, it does affect the eye, and it can be something which is serious sometimes. Now, diabetes and hypertension per se, especially in diabetics, patients do have a propensity of developing vision-related problems, especially cataracts. So I think common people, public might be knowing about the fact that clouding of the lens is an age-related change, right? Like our hair grays. The same way, even the clarity of our lens in the eye can sometimes change, and that can happen as a consequence of a natural aging process itself. And when that happens, when cataracts happen, we of course have to operate and get that treated. I'll come to that later. But in especially in diabetics, an early onset diabetics, sometimes diabetes is detected as early as 30 or late 20s. The duration of diabetes has a direct relationship to the cloudiness or the clarity of the lens, and therefore they are more prone for an early development of cataract. That is one. Second thing is, I think common public will be aware of a condition known as glaucoma. Glaucoma is a condition in the eye where the intraocular pressure, like we have blood pressure, patients are called hypertensives. The same pressure, there is a pressure in the eye. Okay, and normal maintenance of eye requires some amount of pressure in the eye, which is generally less than 20 is what we call as a cutoff. Now, if it increases, it can of course lead to risks. And diabetics, multiple studies done across many decades. It's of course proven now that both open angle is one sort of glaucoma, and angle closure, there is another type of glaucoma. The various types of glaucomas are directly related to diabetes, directly related to the duration of the patient has been diabetic, and also directly related to the control status, whether it's controllable or uncontrollable. And the last important aspect for both diabetics and hypertensives is, the inner part of the eye or the back part of the eye, which we don't see, is the retina. That is where, we get these impulses, the rays of light pass through and it signals up to the brain. It can cause changes in the retina. So there are blood vessels running there. Like people might have heard about strokes happening. The same way, diabetes with maybe a hypercholesterolemia or an elevated cholesterol level or hypertension can affect these blood vessels. And at various grades of diseases known as either a diabetic retinopathy or a hypertensive retinopathy, they invariably can affect these blood vessels and cause sometimes it can be controlled, reversible the loss of vision, or in many cases these might require surgery. So therefore it's very important to understand that yes, you are diabetic hypertensive, don't only get your blood test done, you also have to come for a eye checkup, and that's something which is very important.
What, according to you, Dr. Gairik, are the yellow signal signs, or the warning signs when a person needs to approach an eye specialist for a checkup, especially in those with
So
diabetic tension? Yeah.
So I get asked this question about, when is the right time to visit. Unfortunately, I need to educate the public that even if you don't have any problem, you need to get a yearly checkup done, and that is a must. There are various reasons for that. One is, see, if you're diabetic, you still might be seeing normal. We call it 6/6 vision. Your vision is clear. There's no doubt on that, but you still might have diabetic retinopathy. Even in cases of glaucoma is known as a silent thief of sight. Why is that so? Is by the time patients come to the hospital, they have already reached a stage which is very, very advanced. And it would have been more prudent if they had come earlier. So many of these non-communicable disease associated changes in the eye can be detected very early. So the patient might in fact seem normal, or he might think that, I don't have any trouble. But these problems can be detected on a checkup which a patient comes as a routine follow-up. So many of the patients, I say, for example, we've seen today on the clinic, they might have been normal, that they're well-controlled diabetics, but they still might have been diagnosed as something known as a diabetic retinopathy. So in such scenarios, we become more aware, uh, treat them, and of course keep them on a close watch. So I would suggest to people, don't wait for any sign that your vision is decreasing, or you have to wait till then. Ideally have a yearly checkup irrespective of whether your vision is completely fine. The second aspect is, of course, I mean, you notice a sudden decrease in vision and you're diabetic, or you're hypertensive, or you gradually see a decrease in vision, after after say many months. Of course, that is a red flag. I would say that you have to visit an eye specialist and get it checked, get a detailed eye checkup done. But the key take home is, patients ask me, if I'm okay, why should I come back? But it's very important that, even if you're completely fine, should come back for a regular yearly checkup, just to be on the safer side.
Okay. So did I understand you right? In some people, even if their blood sugars are normal, there could be signs of retinopathy. Is that although?
Correct, correct. So, yeah, so diabetes is a long-standing condition. I'm talking about type 2 diabetes. Sometimes by the time the patient has been even diagnosed to have diabetes, let alone diagnosed to have diabetic retinopathy, it's already at, many years since he might not have known, he might not have been diagnosed. One. Second thing is the duration of diabetes, the chronicity of diabetes is itself a risk factor for changes. So, like I said, it affects the blood vessels in the retina, and early forms of changes in the diabetes, which are known as, non-proliferative early diabetic retinopathies, they can, just show up as mild, blood clots, hemorrhages, as we call it, is in the retina, and it might not involve the vision at all. Only in a more advanced case, where it can involve where the center of the retina, which is known as, a macula. In such scenarios, it might lead to an advanced stage, or sometimes they might be bleeding. In those scenarios, patients come back to us, and that's already at a very, very advanced stage. So you might be a well-controlled diabetic. You still might have changes in the retina, which might have gone undiagnosed. So it's imperative that, one is, of course, if you're diabetic, you need to come back. But if, irrespective of your comorbidity status, any patient, even a normal patient, should ideally undergo a annual routine, complete ophthalmological evaluation.
So when you say ophthalmological evaluation, okay,
Yeah.
we have a lot of these spectacle shops, right, where glasses are sold and we can go and get our eyes checked. So when you say an ophthalmological examination, what exactly do you mean? Can we just walk into one of these stores and get our eyes checked up? Will that kind of handle the whole thing?
So, I mean, nothing to take away from the fact that, there are, of course, a lot of these outlets, optometrists, who are doing eye checkups. Now, you need to understand there's a difference between an optometrist who is trained only in checking your refraction or the power you have and dispensing glasses, right? And an ophthalmologist who is trained in understanding, diagnosing disease conditions of the eye and also treating it accordingly, right? So these are two distinct entities. I am not putting the onus on optometrists. Many of the times, they in fact do screen patients who come to them and send them for a complete checkup. But it's imperative that you come to a center which has an ophthalmologist. Why? Because an eye checkup is not only checking your power. It's of course one aspect that we are checking your power, no doubt. But we are also checking other problems in the eye. We are doing a detailed checkup, looking at your eyelid, looking at your cornea, looking at your lens status. We then, also check your retina. So this all comprehensive evaluation is something which is a must. So the common misunderstanding is that, I've got my power checked, so why should I go to an eye specialist? But the power check is just 5% of the complete evaluation. You still have a lot of other things to be checked, and that is possible only by an ophthalmologist, and that is possible only at an eye hospital. So that's something people should understand and learn to differentiate at the outset itself.
Now, like you correctly said, India today is the diabetes capital of the world. Now, having seen that, as an ophthalmologist yourself, have you seen an increase in the number of cases of, let's say, diabetic retinopathy or glaucoma? Do you see these increasing? And is it more because, even if you do say that it's increasing, is it more because they can access treatment, or are you seeing this because of a general trend where diabetes itself is increasing, or hypertension or hypercholesterolemia is increasing?
So there are two aspects of it. One is, you're right, the availability of good eye care, or general good eye care is improving. And it's not only in the cities, it's even in the rural hinterland. A lot of places do have good eye setups in terms of, I'm not talking about advanced surgeries, but in terms of doing this basic evaluation. So that's important. So understanding the fact that, of course, the outreach and now awareness among people to get their eyes checked is one aspect. And therefore, invariably, we see, a diabetic going to, say, a physician, and a physician recommending that he gets his eye checkup done compulsorily, and therefore he comes to an eye center, and that's when we evaluate and we detect if at all there's a problem. And also the increasing trend is, so it's both. There is also an increasing trend, and the prevalence of diabetes in India itself is increasing, and it's being detected at an early age very often. So younger patients diagnosed as diabetes, so they invariably would have a longer duration of diabetes. And again, chronicity and the duration of the disease itself can have long-term effects in the uh, changes in the eye itself. So that's important. So it's a combination of both, I feel. One is, of course, improved outreach and improved availability of good services to the people, and of course, an overall increase in prevalence of diabetes in India. And that is something which is, of course, worrying, but something which we need to be wary of in terms of addressing not only eye needs. Diabetes affects every part of the body, so that's important.
Would you say that, would you be able to give us a number in terms of what is the percentage of retinopathy or glaucoma that we're seeing? And also, would you be able to tell us from your own experience today, or do you see blindness occurring in people because of these conditions?
So, number, just to get people to understand the magnitude, for out of every, say, 100 patients who are diabetic, okay, so the prevalence of diabetes itself is very high in India, but who are diagnosed diabetics, uh, maybe around 20% of them might have some form of retinopathy. Okay, this is startling because I'm basically trying to say 1 in 5 diabetics may have some subtle findings of retinopathy. All need not be vision threatening. And though the severity or, the advanced stages of diabetic eye disease is, of course, at a much smaller percentage, that's something important to remember. So therefore, any diabetic, you have to get an eye checkup done at least once a year. In terms of glaucoma, that's also startling. There have been multiple studies by leading institutes in our country who have looked at the prevalence and the disease burden of glaucoma. Interestingly, if at any given point of time, there might be almost 30 to 35 million people in India who have some form of glaucoma. It's known as open angle or angle closure. And the interesting point of this disease burden is the number of glaucoma specialists, who are trained to treat them are just in 3 digits. Okay, so that's the startling amount, but not many are diagnosed. And by the time they come to an eye center, like I said, glaucoma is even more of a challenge. It's known as a silent thief of sight because gradually patients will not have any symptoms. They in fact will be completely normal going about, but their field of vision gradually starts decreasing. And by the time many of them get help, it's already at an advanced stage. So when you come for a checkup, a routine eye checkup, these are all the aspects which an ophthalmologist will, of course, look at. Whether you are at risk, your pressure in the eye, your disc, changes in the retina, and if required, intervene. So therefore, that's the reason I'm saying, of course, diabetics at a higher risk. Any patient should come for a yearly checkup. These are conditions which are, understanding of the conditions are improving, of course. And the important aspect is, as I speak, awareness of diabetes and eye, hypertension and eye health is also improving. So that's the good aspect. That's a better aspect. More number of people are coming forward for those checkups. Now, in terms of blindness per se, we do see cases, especially in the center I work. It's a referral center, so you see patients who are referred with sometimes patients requiring surgery. But the bigger picture is in terms of the fact that many of them could have been caught earlier. Many of them, if they had evaluated, at least once a year, and if we had maybe looked at, trying to arrest or trying to prevent the progression, if at all it was detected in terms of diabetic retinopathy, or if cataracts are worsening, or if this glaucoma, it could have, I wouldn't say prevent, we could have at least reduced their, vision or vision related problems. Invariably, what happens is because of maybe lack of knowledge or ignorance, they come at a stage where they, will have to intervene aggressively or do a surgery, and that can get tricky. And in those kind of cases, prognosis is of course poor. So it goes without doubt that screening is very important. A yearly checkup is very important.
Okay. So, do you still see people losing their vision as well, or is it that they come to you at later stages where surgery can kind of, you can intervene with surgery?
Now, so that depends on the grade. Like I said, glaucoma is like hypertension. You have to continue certain drops which are maintaining the pressure in the eye all for almost your entire life. Now, in case medications don't work, there are, of course, surgeries which are there to control the pressure. But again, as you intervene surgically, of course, surgically induced problems can occur, follow ups, compliance to medications. That is one aspect. Second aspect is once you've reached the surgery stage, it's already at a very advanced stage. And therefore, prognosis in terms of how these patients recover is difficult to say. Same goes with diabetes. Diabetes, there are two forms. One is, if I'm talking about retinopathy per se, one is known as the non-proliferative. These are early changes where, the blood vessels can change its, alter its structure. There might be some outpouchings, some bleeding. It can be focal, but invariably as it becomes very advanced, and sometimes it's known as hypoxia induced. The oxygen in the retina is sometimes can reduce, and that induces something known as new vessel or neovascularization. And those kind of scenarios, bleeding is very, very common, and it's known as vitreous hemorrhage. So in those kind of scenarios, sometimes we'll have to intervene with either lasers if it's early, or if it's a very, very advanced case, we'll have to go in and operate the retina and do a vitrectomy and some other steps. I don't want to go into technicality. So it is, of course, a downhill when you are reached the stage where we need to operate. So preventing it from reaching there is something which is very important, and we can do that in 80 to 90% of the patients coming in. Because if they were screened at the right time, maybe an early laser preventing it from bleeding further on would have prevented that patient from going into a surgery, and then again, surgery related, post-operative issues in terms of, sometimes we will have to reoperate. we cannot really talk about how well they recover vision. So it's very important that screening is very important in these cases. Invariably, when they reach surgical stage, it is already at an advanced stage. So that's something important to remember.
Okay. And doctor, would you say there is a difference in the presentation of eye conditions in, let's say, a 30-year-old person with diabetes or hypertension versus somebody who's in their 60s?
So what we're seeing, like I've already told, is, see, one aspect is, if you're looking at diabetes, there is of course type 1 and type 2. Type 1, as they are on insulin, and I don't want to go into the nitty-gritties, and type 2. Now, if you're looking at type 1 diabetes, generally these patients are diagnosed early, no doubt, but also the aggression or the how quickly it worsens is much more than a type 2 diabetic. Now, the challenge in a 30-year-old is, of course, he's diagnosed early on, and also the duration of diabetes. By the time he's 70, he would have been diabetic for 40 years. And like I said, one is, of course, the diabetes. Second is, of course, the intensity or how controlled uncontrolled is. The third, very important, is chronic changes, or the duration of diabetes itself has a role. So these type of patients who have diagnosed and as an early diabetic, 30 is of course very young, invariably can have problems in terms of progression or retinopathy appearing at a much early age, maybe at 40 or maybe at 35. And it's important and imperative that we keep them on a follow-up. So as long as they are coming back to us when we advise you for a follow-up, and we keep you on a close watch, they ideally should not be a problem. So that is one. In terms of how the disease evolves itself, yes, they tend to, younger diabetics generally tend to have a more aggressive form of a diabetic retinopathy as an opposed to a person who's 60 years old. But again, management strategies for both, diabetic induced changes in 30 and 60 would still remain the same. The screening would still remain the same. Our diagnosing and interventions would still remain the same. It's just that we will be more closely watching a 30-year-old, for early changes. And we tend to be, of course, more wary of the fact that they are younger. The productivity, the productive life is much more than a 60-year-old. So, but otherwise, in terms of intervention strategies and screening protocols, it's more or less the same.
Would you have any real life examples that you share with our viewers so that they can understand the seriousness of what you're talking about?
So I think, when you're talking about scenarios where a patient has lost their vision and reversed, so the, occlusions, for example, people might have heard about strokes. I'm sure, that, there is a blockage in the blood vessel in the brain. There are blood vessels, like I told, in the eye as well. And one of them, there are two types of blood vessels. One is known as an artery, one is known as a vein. Now, many of them are perfusing or are supplying areas which are very, very vital for our vision. And one of the conditions which comes to my mind is, something known as a central retinal artery occlusion, where sometimes, one of the main supply chains get blocked, something like a stroke in the brain. And that causes this immediate sudden drop in vision. And why is it important to reverse and come immediately to an eye checkup is because if these patients come early, within 3 to maybe 6 hours of the onset of the symptoms, many of the times we've been able to reverse it completely, in terms of whatever intervention strategies we do, to break that area where there is an occlusion, and so that that area which is deprived of the blood supply can actually get back the blood supply quite quickly. The same thing holds with veins in the retina as well. Sometimes diabetes can be at a risk for something known as vein occlusions, and if not completely reversing, but at least 70 to 80% of the damage which can or might be induced can be stopped if you get to an eye care provider as soon as possible. So these are the examples which come to my mind in terms of problems which might happen because of diabetics and hypertension. Yeah.
Okay. What about supplements? Today, the supplement market in our country is like booming. So, what are
Yeah.
the nutrition? Of course, we know that nutrition plays a big role where diabetes and even hypertension, high cholesterol, all of that is concerned. But what about supplements? Are there supplements that people should be aware of? Should they be taking supplements for their overall health, actually for the eye health, not overall health. Yeah.
So I think there are a lot of these over-the-counter medications which are available, multivitamins, and people obviously off the hand give advices that use multivitamins. But when you're looking at eye-specific conditions, there are supplements for various conditions in the eye, and it's of course advisable that you get it done through an ophthalmologist and don't take over-the-counter medications. Like for example, there is a condition in the eye which is known as an age-related macular degeneration. So what is it is that area which is macula in the retina in the nerve layer gradually, as age progresses, there are some deposits there, and the functionality is gradually worsened. And these are, it's not that you can do a surgery to reverse it. It's an age related change, so you need to kind of arrest and give extra supplements to increase the functionality of the existing structure which is present in the eye. So in certain scenarios we do give supplements, something known as lutein, zeaxanthin, there is vitamin C, there's vitamin E, carotenoids as we call it. So these are actually proven medications, proven by trials, multi-center trials across the world, where age-related macular degenerations is one of the indications where supplements can be used. Now, these omega-3 fatty acids, or these vitamin supplements, there are some bilberry extracts or something known as macuberry extracts. These again have also shown efficacy not only in retinal problems but also overall they reduce the inflammation in the eye, and inflammation induced problems which can happen. So if it is a macular degeneration, it can kind of arrest and control the inflammation. Even omega-3 fatty acids for that matter has been used for dry eyes, if people are aware of that. There are also newer extracts and oral medications which are used for again, dry eyes as one of the conditions. So whether it's the front part of the eye, back part of the eye, there are supplements, no doubt. But what you can take and what are the risk factors? So in certain scenarios, we shouldn't be giving those supplements. For example, certain extracts for dry eyes, we should be wary of, especially in diabetics. People might not be aware of that. So again, they come to us. We will, every patient is different. Every patient is unique.
Okay.
We will titrate and give you the supplements based on your needs. It's not a blanket rule. Not everybody with this condition will be given supplements because there is a catch to it. So that is something which we of course look at evidence-based medicine. Existing work which has been done to prove the efficacy of these supplements. That's something important because just taking a multivitamin tablets off the counter is not enough. And multivitamins might not be useful. Like I said, vitamin C might not be there in the multivitamin tablets, but that's very essential for eye. Vitamin E might not be there. Copper and zinc. These are some micronutrients which are also required to be in certain tablets. So those special formulations are which, of course, we give on certain conditions. But that's again something we look at the patient, look at his existing comorbidities, and then take a call whether a long-term supplement would be safe. So never go under the understanding that any supplement will be safe. Even a multivitamin tablet can have its own consequences. So I think patients should be wary of that, and as long as you come for a checkup, it should be fine.
So what you're trying to say is that today there's a lot of information available on the internet. So every supplement that's advised by on the internet, on blogs and things like that, it's not for us to just take it and pop them as if we feel so, but actually get a prescription from somebody who has the experience to treat ophthalmic problems, right?
Yes, yeah.
Dr. Gairik, today there's a lot of impetus in our country about genetic testing. It's slowly becoming commercially available. Genetic testing, well, I was a student and even earlier in my practice, it was something that we did in research facilities. But today we are seeing that it is being available, it is being made available for even the citizens to just, for the common public to go and access it, right? So what do you think about genetic testing for eye-related problems? What's your take on it? How important is it? And what is the impact that it's going to have in the future?
So one aspect is I think the next century would be driven by a lot of interventions, things which we couldn't do earlier. The color of the hair I have, many of the things I have is because of certain inherited traits. Now, likewise, even disease processes sometimes can be inherited and can be due to inherited conditions. Second is certain mutations in genes which are more prone for changing. That is also something which is important to remember. Now, when we're talking about genetics, it's a wide branch, which also involves identifying such patients, counseling patients, and where are we at this intervention stage? So at the center I work at Narayana Nethralaya, we in fact have started trials, and we are, I think, maybe in terms of ocular genetic trials, maybe the first, of course, the first in our country, and I think first in Asia, and maybe the first few centers in the world where we are looking at gene therapy. Now, you need to understand, one is identifying these patients. Now, which one of these patients are at risk? If I have, say, an inherited retinal dystrophy or some problem in my retina or some problem in any other part of the eye, first step goes in identifying what that problem is, which area or which gene is involved. And most important aspect prior to actually treating is genetic counseling, where we are, of course, sitting down with the patient, talking about family members, tracing out something known as a pedigree chart. One. Now, we are moving away from just this. We did till now is just restrict ourselves to counseling, and then the options after that were limited in terms of what we could actually do, in terms of treating such patients. So, a patient who has, say, a retinal problem, uh, other than telling him that, avoid consanguinity, or, marrying in the family, or identifying risk factors, there's not much we could do in terms of the patient himself, whether we could, arrest the worsening of his vision, whether we could reverse. That is where I think a new paradigm dimension in genetics and gene therapy. So it is now the generation, the next maybe century would be in repair and regeneration, where we are going into strategies of going into the cell, finding out what is the gene which is abnormal, removing the one which is abnormal, and putting a normal gene into it. And we have done work at the Grower Research Laboratory, which we have with Narayana Nethralaya, where we have created a system, where one of the, maybe the only centers where you're looking at, specific eye condition gene therapies. And we're using viral vectors, where, for example, we're using a virus, putting that into the cell, and, removing the gene which is problematic, and then inserting a gene which is well functioning. So till now our understanding of genetics was only in terms of identifying those patients, identifying whether it is inherited or whether it's a genetic problem, and doing counseling. But I think now, from the next many years, we would be focusing on targeted treatments which are, in terms of focused on certain inherited problems in the eye, and whether we can arrest it and reverse it. So I think that is what will go on a long way in addressing many problems, even if you're talking about eye cancers per se. Many of them are, of course, inherited in terms of genetic mutations. The epigenetic in terms of the other risk factors is something we cannot really, that's something we cannot control. Uh, that's again based on a patient. So for people to understand, for example, if I have a gene which is more prone for, say, a lung cancer, but what is the additional risk factor would be smoking. So those would be the additional epigenetic factors. So that is something which is we can of course educate patients, but not completely control, but once we have a gene which is abnormal and driving a patient to a risk to, say, have a cancer, or have, say, a dystrophy or a problem in the cornea or the retina, can we prevent that patient from developing into it? That is something which is important. And can we repair the gene which is defunct or which is not functioning properly? I think that is where the next phase of a lot of the work in eye research and ocular genetics would be. So, yeah.
Interesting. Now, also to get back to your specialization or your area of interest, artificial intelligence. Tell
Yeah.
us the role of artificial intelligence in eye health, and what's your work?
So yeah, so we also not only see patients, we also do a lot of, research in terms of patient driven. So this will invariably be translated to our clinics. And what my field of interest is, I'm also doing my PhD on artificial intelligence. So I think artificial intelligence every year we keep hearing talks that this is the future, this is the future. But I normally tell that this is not the future, this is already the present. And AI driven analytics is something which is part and parcel of many things, many things which are you routinely do even at home. For example, the app you open, the search preferences, those are all AI driven analytics. They kind of analyze your data over the last, say, maybe 2 months, and based on what you have clicked on that shopping app, they would give you the preferences later on for. So that is a very simple aspect. Now, in terms of AI driven analytics in healthcare, it is here to stay, and it is very, very important, not only in terms of research, but also in terms of optimizing treatments, reducing errors, and assisting clinicians in kind of improving the patient workflow and also outcomes. Now, one aspect is, of course, integrating this into our existing databases and softwares where we can use big data analytics and look at certain problems. So, for example, if there are 100 patients walking into my clinic, there are so many permutations and combinations which invariably would be there, and sometimes it can be difficult for a clinician. It's not an error or a shortcoming of a clinician, but invariably these are some parameters which we might not, delve into because it gets too complicated. So that is where AI driven models, might, for example, if you walk into my clinic, they look at your age, your gender, your other risk factors, your past medical records, history. If you've had any intervention in the past, what was the outcome of that intervention? So therefore, if I do another intervention or operate or or just treat you with medications, what would be the most preferred outcome, or will there be a good outcome or not? So that is just one of the examples. Other aspects in AI driven analytics, which we are also doing, these are all being done in our center also, is in terms of streamlining workflows. Patient walking into the hospital, how do you optimize, reduce their waiting times? How are they driven correctly to the correct, the place where they need to go to? In terms of discharge summaries, in terms of, documents, processing, multiple departments, putting that into a summary. These are all analytics and big data analytics, a little bit of machine learning and computing. So these are all, gone are the days where we should tell me that I just know medicine, but you'll have to kind of go with what is the next leap. And this is something we have already been doing products. Importantly, we have also published a lot of work on specific disease processes. If you're looking at keratoconus, so what will predict whether this patient will worsen in the future or not? We've developed apps. For example, you walk in, I can put in your individual blood parameters, I can put in certain scans, images into that, and the AI will give me a risk stratification score and tell me that you are actually at a higher risk than some other patient, for worsening of that disease condition. So these are already some things which are very much there in our system. Awareness, luckily, is improving, and AI is very much there. I mean, it's the present, and we'll have to, how best we utilize it is, I think, very important. Yeah.
So let me just summarize this discussion for our viewers. According to what you advise, a person with a chronic condition like diabetes or hypertension, it's better that they have annual eye checkups, because a lot of these conditions like retinopathy, glaucoma, sometimes they are very silent, right? And a person may not know that they have them unless they go for an eye checkup. So a yearly eye checkup is what you advise.
If they are normal, yes, a yearly eye checkup. And again, if we do detect certain problems, we will of course call them back for a more frequent checkup. Yes.
The second thing is looking out for warning signs, like if the peripheral vision is reduced or if there's a sudden drastic loss in the vision, then rush to the hospital, rush to the nearest eye hospital. And like you said, if they do it within 3 to 6 hours, there's a bigger chance of being able to save the person's eyesight, right? The third thing which you kind of drew our attention to is the use of supplements in ophthalmic care, where it's better not to just look at what the internet is telling us, but to go to the doctor, and the doctor will decide what kind of supplements will actually suit each individual, right? And then you also spoke about things like using gene therapy. which is evolving today. And of course, all of this is now cutting edge medicine where we can do testing, we can know who's at risk, and slowly we would also have gene therapy to modify these conditions. And
Yes.
your area of interest, and I saw your eyes actually sparkle when you spoke about artificial intelligence and how it's going to be, it's going to turn around the way we practice medicine, right? Yeah. So thank you so much for your time, Dr.
Thank you.
I think our viewers will definitely learn a lot from what you had to say, and I hope that they take what you said to heart and start looking at going in for a regular eye checkup. And hopefully, we'll be able to avert blindness or loss of vision from setting in. Yeah.
Thanks a lot. Thank you for the opportunity. It was lovely interacting. Thank you.
I hope this discussion with Dr. Gairik Kundu has been helpful, and I really hope that it motivates you to go and get your eyes checked. Until next time, this is Dr. Nirmala signing out. And remember that wellness begins with your plate. And also remember that prevention is better than cure.